Hello, everyone. My name is Emily Dowling. I am from the University of Florida in the Translational and Applied Behavioral Science Lab. Today, I will be presenting on enhancing behavioral interventions for children with autism spectrum disorder with the Smart App for caregivers and staff. This project was developed with funding from NIH and NSF grants. Our study was a part of a multi-site project. On the screen are some collaborators who were a part of that multi-site project. ABA services are regarded as effective evidence-based interventions to address behavioral challenges and skill deficits of children diagnosed with autism. Previous literature shows that early intervention can significantly decrease the lifetime cost of care. However, even though early intervention is emphasized, there are limitations to accessing necessary services. Let's dive into some of these challenges. There are many variables that impact access to services, including limited number of trained experts, access to behavioral services in remote areas, high rates of turnover, maintaining high treatment fidelity, and consumer dissatisfaction, to name a few. We will first discuss the limited number of trained experts and access in remote areas. Although the number of behavior analysts has increased in recent years, there are still not enough providers to address the disparity in access to critical care for individuals diagnosed with autism. Access to care is especially difficult for individuals living in remote communities. Yingling et al. 2022 evaluated trends in geographic access to BCBAs per children diagnosed with autism between 2018 and 2021. They found that approximately 22.3 million people and 29,297 children with autism, or 5.1%, lived in a county with no BCBAs. 37.4% of counties had no BCBAs, and 8.2% had no BCBAs and no BCBAs in bordering counties. Approximately 65% of counties had 25 or more children with autism per BCBA, suggesting low access across the country. These results clearly emphasize the struggle in accessing services, especially in remote areas. Another factor that contributes to the disparity in access to services is high burnout rates and turnover of service providers. Burnout can include stress, job security, lack of support from organizations, work-life balance, or overall job satisfaction. Burnout can affect an individual's well-being, delivery of quality services, and can result in turnover. The turnover of service providers, accelerated by high rates of burnout, has only exacerbated the issue of access to necessary services. Kazemi et al. 2015 reported that turnover rates for direct support staff working with individuals with intellectual disabilities had an average turnover ranging from 45 to 75%. This statistic is higher than that of the average yearly voluntary turnover rates across all industries, which was 17.9% in 2011. With burnout rates and turnover rates this high, it is increasingly difficult to obtain access to service providers and receive quality services that result in consumer satisfaction. Burnout can lead to turnover, which can result in the remaining employees struggling to provide quality services when novice employees take the place of experienced employees. This disruption can lead to decreased quality of services, resulting in negative impacts on consumer progress and satisfaction. High treatment fidelity is important for maintaining treatment outcomes as well as consumer satisfaction. Brand et al. 2019 evaluated 13 studies of parametric analyses that focused on manipulating errors when training a new skill. Results suggest that consumer outcomes were better when practitioners implemented procedures with perfect integrity. Further, consumers responded with increased accuracy and fewer trials to mastery during conditions involving perfect integrity compared to conditions with fidelity errors. It was also noted that a decrease in treatment integrity can affect treatment outcomes to varying extents across individuals. Taken together, behavioral procedures with low treatment fidelity can impact consumer satisfaction. So with all these barriers, where does that lead us? AI enables computers and other automated systems to perform tasks that have historically required human cognition and human decision-making abilities. Research in AI is therefore concerned with the understanding of mechanisms underlying thought and intelligent behavior and their implementation in machines. The full AI endeavor is inherently multidisciplinary, encompassing the research necessary to understand and develop systems that perceive, learn, reason, communicate, and act in the world, exhibit flexibility, resourcefulness, creativity, real-time responsiveness, and long-term reflection, use a variety of or reasoning approaches, and demonstrate competence in complex environments and social contexts. So how can AI be advantageous in applied settings? Well, AI can aid in providing moment-to-moment decisions, such as when or how to deliver instructions, what to do when a learner emits a correct or incorrect response, how much support to provide a learner, and when to fade or add support, to name a few. Through AI assistance, it is possible to increase procedural integrity and, as a result, improve clinical outcomes. Collaborators from Temple University developed a smart technology platform that provides caregivers and paraprofessionals with real-time automated monitoring, guidance, and feedback when implementing behavioral interventions independently. GAINS, or Guidance Assessment and Information System, is a smart technology platform that uniquely incorporates knowledge of behavioral theory and practice to provide an individualized navigation system for staff or paraprofessionals and caregivers implementing behavioral interventions that help learners acquire skills and improve prosocial behaviors. So the instructor uses GAINS like a driver uses a car's navigation system. GAINS knows where the instructor and learner are on the learning path. This technology could be useful for minimizing the resources required to support caregivers and staff in remote or underserved locations, and could aid in maintaining high long-term treatment fidelity to mitigate likelihood of relapse. Here's what GAINS will look like. GAINS will provide instructions on the current step in the behavior protocol. Instructors or caregivers will either mark the response as correct or incorrect based on child responding. If the individual marked the step as correct, GAINS will progress to the next step. If the individual marked the step as incorrect, GAINS will provide guidance on the next prompt to use. GAINS has been evaluated with direct service providers helping adults with autism learn vocational skills, in this case, box assembly. Overall, by using GAINS, there's an increase in both direct service provider implementation as well as participant correct responding. Similarly, GAINS has been evaluated with direct service providers helping adults with autism learn another vocational skill, laundry. The use of GAINS drastically increased correct implementation for the 4 dyads. Griffin et al. Evaluated GAINS with staff teaching children with IDD to wash their hands. GAINS was implemented with 4 behavior technicians' implementation of least to most prompting, total task chaining, and time delay. Findings demonstrate that all behavior technicians increase procedural fidelity when using GAINS and reach mastery criteria in less sessions. In the current investigation, we evaluated GAINS to teach 2 behavior technicians from a university-based ABAI clinic to implement EI protocols with children diagnosed with autism. Baseline consisted of a paper protocol, and intervention consisted of GAINS guidance. Here are the results of the behavior technician's implementation of EI protocols when using the paper protocol versus when using GAINS. On the x-axis is sessions, and on the y-axis is percentage correct treatment implementation. Results show that the use of GAINS showed a moderate increase in accurate treatment implementation for the behavior technicians across 3 different early intervention programs. Let's take a look at Anna first. For Anna, treatment fidelity was around 45% while using the paper protocol for listener responding. Once GAINS was introduced, treatment fidelity increased to an average of 83%. For intraverbal, Anna's treatment fidelity was around 64% when using the paper protocol. Treatment fidelity increased to an average of 85% once GAINS was used. And last, treatment fidelity was on average 63% when using the paper protocol for teaching imitation, and treatment fidelity increased to around 94% when GAINS was introduced. Now on to Helen. Treatment fidelity was approximately 43% when using the paper protocol for listener responding. Treatment fidelity then increased to around 78% when using GAINS. Next, for imitation, treatment fidelity was on average 49% when using the paper protocol and increased to an average of 82% when using GAINS. Last, for visual discrimination, treatment fidelity was on average 51% when using the paper protocol and increased to an average of 82% when GAINS was used. Social validity in this study showed that the participants rated GAINS highly in terms of ease of use, straightforward data collection, provided guidance on what to do when a client errors or does not respond, and aided in reinforcement reminders. Thus, Gains appears to be easy to use and efficient as rated by behavior technicians. In the current investigation, we also wanted to evaluate the use of Gains with caregivers. So, Gains was evaluated with 3 caregivers implementing behavior protocols with their child. The skill selected for acquisition was based on the caregiver's preference of what they thought was most important for their child to learn. So, skills in this study included imitation of pointing a finger, brushing teeth, and brushing hair. As before, baseline consisted of a paper protocol and intervention consisted of Gains guidance. Here are the results of the caregiver's implementation of the behavior protocol with their child using the paper protocol versus when using Gains. Again, sessions is on the x-axis and percentage of correct responding is on the y-axis. The closed circles represent treatment fidelity and the open circles represent child responding. Overall, Gains alone was effective for 1 caregiver and feedback had to be added to the other 2 caregivers. Let's take a closer look at Kara. For Kara, treatment fidelity was on average around 62% when using the paper protocol for imitation of pointing a finger. Treatment fidelity increased to 100% after 4 sessions of using Gains. Child responding stayed at 0% throughout baseline and when Gains was introduced, and this was likely because the skill that was chosen by the parent was too advanced and the child lacked the prerequisite skills to learn how to imitate pointing their finger. For Ethan, treatment fidelity and child responding was low when using the paper protocol for brushing hair. When Gains was introduced, treatment fidelity remained close to baseline levels, but child responding showed a slight increase. Once feedback was introduced addressing the errors the caregiver was making while using Gains, treatment fidelity showed a moderate increase, but still below 80% levels. Child responding showed an increase when feedback was introduced. This participant is still in progress, and we plan to provide a model next of how to use Gains to see if that will increase treatment fidelity to 80% or above levels. Last, for Emma, treatment fidelity and child responding was low and variable when using the paper protocol for brushing teeth. Once Gains was introduced, treatment fidelity increased to an average of 63%. Child responding during Gains increased to an average of 33% correct responding. Feedback was then introduced addressing the errors that the caregiver was making, and following feedback, treatment fidelity increased to 94% and child responding increased to 47% correct responding. It should be noted that both Ethan and Emma chose a complex multi-step skill, and it's possible that the complexity of these skills impacted treatment fidelity and was why feedback had to be introduced. Only 1 caregiver so far has completed the usability survey, but they rated Gains highly in terms of ease of use and said the audio and written words together helped them understand better. Overall, we found that Gains improved procedural fidelity, it was accepted by users in clinical settings, has the potential for scaling delivery of behavioral services by caregivers, and for some caregivers, robust initial instructions may be important for treatment fidelity when using Gains. The potential for using AI in ABA settings can provide various benefits. ABA can harness AI tools to expand scope and capability. AI can benefit underserved communities by increasing access. ABA will become more consistent, for example, procedural fidelity across contexts. Caregivers will become more involved in treatment. ABA practitioners, for this reason, must become fluent in current technology, and supervision of clinical services will change for the better. Thank you all for listening. Here's a QR code for our lab if you are interested in more of our work.